Slide.
Yes po, Doc.
Okay, sige. We will continue with our discussion, the examination of the heart. So we're already on the auscultation. So after listening to your first and second heart sound, because it is very important when you are examining the heart to, especially during auscultation, to first identify which one is your first heart sound and which one is your second heart sound. Because once you have already identified the heart sounds, you now proceed with determining any other abnormal sounds that you hear, identifying any abnormal sounds that you hear. So usually, your heart murmurs will depend. So the type of murmur will depend on at what part of the cardiac cycle this murmur occurs, like whether it is systolic in timing or diastolic in timing. So that's why very important to identify first your first heart sound, because if, for example, you hear a murmur after the first heart sound or between the first and the second heart sound, it is usually systolic in timing. Now, if it occurs after the second heart sound, it is usually diastolic in timing. So that's why it's very important that you you identify first and concentrate on your first and second heart sound. Once you already have identified, then you now proceed with identification of the other heart sounds or abnormal sounds that you hear. Okay. So heart murmurs are longer in duration than your heart sounds. They originate within the heart itself or in its great vessels, and they are usually caused by one of the following mechanisms. So pwedeng it is secondary to a flow across a partial obstruction. So when you have stenosis, this can create an abnormal sound because it creates turbulence across, because of the gradient created by the obstruction. It will cause turbulence of the flow so that you will hear an abnormal sound. So next is a flow across a valvular or intravascular irregularity without any obstruction. So pag irregular, ganun din because the flow of blood is lamellar. So pag merong mga humps and bumps, it will create turbulence. So it will now cause an abnormal sound. So next, the mechanism is an increased flow through a normal structure. So mag-create also in turbulence across that valve structure or any structure where there is an increased flow, there will be an abnormal sound. Then another is if there is flow into a dilated chamber. So when the chamber is dilated, edge current. So it will also create an abnormal sound. So another is backward and regurgitant flow across an incompetent valve. So pabalik. So it will also create an abnormal sound. And next is shunting. So if there is shunting of blood out of a high pressure chamber or artery through an abnormal passage, like for example, when you have holes in a patent ductus arteriosus, in VSD, and atrial septal defect, it will also, and then there is shunting of blood, it will also create a sound. So auscultation, you need to determine the intensity of the murmur. So your murmurs has been described by Freeman and Levine in 1933. So the grading of the murmur could be grade 1, which means that the murmur is very faint and needs tuning in. and focused attention. Grade 2, it is faint but easily heard upon placing your stethoscope on the chest. And then grade 3, it is moderately loud and intermediate. And grade 4 is intermediate intensity murmur with a thrill. So you will now appreciate a thrill. And then grade 5, you will hear even the murmur, even with the rim or edge of the stethoscope partly touching the skin. And grade 6, you can hear the murmur even if the stethoscope is removed slightly from contact with the chest wall. So these are the gradings of your murmur. And during your reporting or recording of your physical examination, you record your murmur whether it is grade 1, 2 to 6. Huh? So systolic murmurs. So pansystolic murmurs are usually regurgitant. So they are regurgitant murmurs either from mitral insufficiency, from tricuspid insufficiency, or from a ventricular septal defect. So pag sinabing pansystolic, the murmur can be heard all throughout from S1 to S2. So that's why, as I've said earlier, you need to identify first your first and second heart sound, because if you will not be able to identify the first and second heart sound, you will not be able to identify also the murmur and the type of murmur. So as your systolic murmur or pansystolic murmur or holosystolic murmur always starts with S1 and it goes beyond S2. So it is predominantly high pitch, soft, and blowing. So for MR, it is usually produced by retrograde flow from a high pressure area through some abnormal opening into an area of low pressure. So all throughout your, from S1 to S2, you will hear the murmur. Usually the murmur of mitral regurgitation is heard at the apex. Huh? And it may radiate to the axilla and to the back. Then you will have tricuspid regurgitation, which is also systolic in timing. So it is heard best at the left lower sternal border here, louder with inspiration. So when you ask the patient to inspire, this will cause an increase in the intensity of the murmur. So in dako, loud, it becomes loud with inspiration. And this is called as your Carvalho's sign. So for ventricular septal defect, you will hear also a holosystolic murmur that is best appreciated at the lower end of the sternum. So short systolic murmur can also be heard, and that is in addition to your classical pansystolic regurgitant murmur seen in mitral regurgitation, ER, and VSD. So here, the murmur starts with first heart sound but may suddenly stop during early systole. Ganito lang siya. So it's not all throughout. It's not all throughout your what's this? All throughout your systolic cycle or your systole. So hanggang dito lang siya. So it's a short systolic murmur. It can be heard in small VSDs. So what happens when in VSD? So the explanation for this is due to the, as your ventricular volume becomes smaller after maximal ejection, the defect will seal off. So the murmur will cease. So kaya hanggang mid-systolic lang siya. So for late systolic murmur, this can be appreciated in mild mitral insufficiency. So the valve is competent during early systole, but as ventricular volume decreases, now the leaflets become incompetent and a murmur begins, which builds up in late systole, becoming maximal at the time of S2. So paganyan siya, crescendo. Then you can also hear systolic murmurs in patients who have mitral valve prolapse. So usually the murmur heard in mitral valve prolapse are usually affected by positions. Like for example, during squatting, it will increase in intensity. Squatting, standing. So you will have a delay in the click and murmur, and it may become faint. So click occurs earlier, so the murmur may become louder, just like this one. So during systole, you will have a reduction of your left ventricular volume. This is in mitral valve prolapse. And it reaches a critical point at which the mitral valve no longer coaptates. So at this point, the click will occur and the murmur follows. So with the maneuver, this will cause an alteration in the murmur. So that's why it's called as click murmur syndrome. So what is the effect of squatting? So when you squat, you increase your venous return. And so if you increase your venous return, you will also increase your left ventricular volume. And a reduction in your a reduction in myocardial contractility or an increase in your impedance to the left ventricular emptying, the click will be delayed. So the murmur will be relatively brief in this case. With standing, you will have a decrease in left ventricular volume because pag na-stand because of gravity. And there is a decrease in your impedance of your left ventricular outflow. So you will have decreased venous return or augmentation of contractility. So you will have an earlier prolapse of the mitral valve. So this is just a historical note. So mitral regurgitation was first noted by John B. Barlow in South Africa, and he published a paper on mitral valve click due to billowing of the mitral valve and a late murmur previously thought to be extracardiac in origin. That's why the other name for your mitral valve prolapse is your Barlow syndrome. So this became the most common valve disorder in the world, affecting 5 to 10% of cases. In 1964, John Michael Creeley of the Johns Hopkins introduced the term prolapse. So when we say mid-systolic ejection murmur, your mid-systolic ejection murmurs occur during the period of ventricular ejection. So in this period, diba? The onset of murmur is separated from your S1 by the period of isovolumetric contraction, and the murmur is crescendo, decrescendo in nature. And it will stop before the respective semilonal valve closure. So ejection murmurs can occur in patients who have aortic stenosis. You can hear the murmur at the second ICS, right parasternal border. So next is your coarctation of the aorta. So you can hear the murmur coarctation of the aorta by listening over the upper thoracic spine. And then you have the splitting of the second heart sound. that is heard in pulmonic stenosis and atrial septal defect. So we already have actually discussed this in our previous lecture, in my previous lecture. So the wide splitting of the second heart sound may be due to to the late closure of the pulmonic valve, as when you have conditions like right bundle branch block, pulmonic stenosis, and atrial septal defect. However, in atrial septal defect, the splitting is both wide and fixed. So this is what happens, di ba, nung diniscuss natin to. With inspiration, so you will have a normal splitting of the second heart sound heard in the pulmonary during respiration. However, when you have atrial septal defect, you will have a wide splitting of the second heart sound, wide and fixed splitting. So in atrial septal defect, you will listen for the murmur in the pulmonary area during normal respiration. So you can also have splitting of the second heart sound during mitral insufficiency or when you have ventricular septal defect. So with early closure of the aortic valve, wait. So with early closure of the aortic valve, you can hear the splitting kasi early ania closure, the splitting of the second heart sound. So A2 and P2. So ejection murmurs can be heard also in patients who have pulmonic stenosis. So in pulmonic stenosis, the murmur will diamond shape, and then it will slowly or becoming faint as it approaches diastole. So the degree of the murmur depends on the degree also of the stenosis. So you can have mild, moderate, and severe pulmonic stenosis. So in valvular pulmonic stenosis with intact ventricular septum, the right ventricular systolic ejection becomes progressively longer. So you will have with increasing obstruction, I mean to the outflow. Now the murmur becomes louder. So here the murmur becomes louder and longer. It may even envelope your A2 and P2. A2 and the P2 closure occurs later. So you will have a wide splitting or a splitting. Oh yes, the splitting becomes wider. So however, your P2 will be difficult to appreciate because the aortic closure sound of your A2 is lost in the murmur, and P2 becomes progressively fainter, and then it is usually low pitch. Now, as the pulmonary diastolic pressure drops to 0, you will have isometric contraction, and this will shorten to the point where your pulmonary ejection sound now fuses with the first heart sound. So kaya ganyan yung niya, diagram, because it almost fuses with the first sound. So in severe pulmonic stenosis with concentric hypertrophy and decreasing ventricular compliance and atrial filling sound, your A appears. So in tetralogy of Fallot, you can also hear a systolic murmur. So the murmur is systolic. So it starts with during pre-systole approaching towards diastole. and you have to listen the murmur at the pulmonary area. So the degree also of the murmur depends on the degree also of the defect or of the congenital defect of your tetralogy of Fallot. So in tetralogy of Fallot, with increasing obstruction at the pulmonic infundibular area, you will have more and more right ventricular blood that is shunted across the VSD. Kasi may VSD yan. That's one of the component of your tetralogy of Fallot. So you will have less flow across the obstructed outflow tract. Now with increasing obstruction, the murmur becomes shorter, earlier, and fainter. And the pulmonic valve closure sound is absent when you have severe TOF. So the large aortic root in tetralogy of Fallot receives almost all of the cardiac output from both your ventricular chambers and the dilated aorta. So this dilatation is accompanied by your ejection sound, which maintains the characteristic of an aortic rather than a pulmonic ejection sound. So in mitral stenosis, so if you look at the valve, so this is a normal valve. So it opens during diastole to fill your ventricle. So when you have mitral stenosis, the valves are is this thick? They are thick. They are thick, so that when it closes, or when it opens, when it opens, it creates a sound. Kasi stiff naman here, unlike this one in normal. So when it opens, inhibited it iya opening. So you will hear a sound, and you call that as the opening snap. So opening snap is diastolic. Diastolic yan timing. Kasi di ba pag open hand valve, so it causes a sound because of the stiff valve. So if you will locate the opening snap, so it should be after S2. After S2 here. So that's why. So the opening snap if after S2. Now, during expiration, hindi mo maririnig yung P2. But during inspiration, you will hear P2 first before the opening snap. So the opening snap of the mitral valve is high-pitched sound. Huh? It is best heard between the apex and the left sternal border, and it may radiate to the pulmonic area. So it should be differentiated from pulmonic closure by listening for the three sounds of the aortic closure. So pulmonic closure and the opening snap occurring in rapid succession during its. So ito yung sabi ko kanina. A2 first, tapos P2, nauna yung P2 before the opening snap. Then you can have feeling murmurs as in mitral stenosis. So for mild ES, the diastolic gradient across the valve is limited to two phases. So you have the rapid ventricular feeling in early diastole, and then you have your pre-systole and the rumble that occurs during either or both of these periods. So kaya diastolic in timing. So when you have severe mitral stenosis, a large gradient exists across the valve during all of the diastolic feeling period. So the longer the rumble, the more severe the stenosis. So as your left atrium pressure becomes higher, the time from the aortic closure sound to the opening snap shortens. So your secondary hypertension, pulmonary hypertension may result in a louder P2 sound, and the splitting becomes narrow. So for mitral stenosis, you will hear the murmur, as I've said, during diastolic period. So after your S2, you can hear it at the apical area. So S1, S2, then you will hear the opening snap. So diastolic insufficiency or aortic insufficiency may also produce a diastolic murmur, as well as your organic pulmonic insufficiency. For aortic insufficiency, usually the murmur occurs after the second heart sound. So it's loud and then becoming faint. So in AR and PR, secondary to pulmonary hypertension, so the murmur starts almost simultaneously with S2. So the gradient between your aorta and the left ventricle is maximal. So it's almost instantaneously, and then slowly it will decrease. And the murmur also has high pitch in character. So you have slow decrescendo murmur. For valvular PR without pulmonary hypertension, so this is manifested by a murmur which starts later. So kaya ito siya, later. Unlike here, na early, even simultaneous with your S2. So it's manifested by a murmur which starts later and has a rapid crescendo, kaya parang diamond siya. Rapid crescendo, with longer decrescendo. So longer decrescendo, rapid, tapos longer decrescendo. So they are low pitch, so lower than the usual early diastolic blowing murmurs because the pressure gradient from your PA to the right ventricle is very slight. So this is how you use your stethoscope. So you can use the bell and the diaphragm. So you can use the bell and the diaphragm. So for the diaphragm is used for high pitch. Diba sinabi ko noon? And then the bell for low pitch. So if it is a diastolic semilunar valve murmur, so it usually starts with S2. And then it is becoming faint or there is decrescendo and it is blowing in character. So you can hear this diastolic semilunar valve murmurs by letting your patient sit. So you let the patient sit up, and then ask the patient to lean forward and press hard with the diaphragm during held expiration. Meaning to say, di mo pinapautok mo ha para mo madinig. So usually, you can hear the diastolic semilunar murmur in this distribution. So from here, so we call this as your sash-like distribution. Kasi pwede siyang mag-radiate to the apex here and even to the neck. For pulmonary regurgitation, it is also a diastolic blow or a diastolic blowing murmur that occurs after your P2 or even simultaneous with your P2. So you can hear it here at this area at the second ICS, and it may radiate ticadi at the left parasternal area. So this is a murmur of your patent ductus arteriosus. So the murmur of your patent ductus arteriosus is continuous and machinery-like. And description ito ya. So it occurs all throughout. So from S1 to S2 and then to the next cycle. Then you need to identify or differentiate continuous murmur versus a to and fro murmur. So for a continuous murmur, it is an abnormal, created by an abnormal communication between a high pressure system and a low pressure system. So it produces a large pressure gradient that exists throughout the cardiac cycle. So they are diastolic murmurs. So they are also continuous murmurs. So the classical example is your PDA, patent ductus arteriosus. So at times, your continuous murmurs may be confused with the to and fro murmur. So the to and fro murmur is a combination of an ejection murmur and a murmur of the semi-lonar valve incompetence. Ito siya. Kasi this one is a continuous murmur. This one is a to and fro murmur, a combination of the ejection murmur and the murmur of valve incompetence for a semi-lonar incompetent valve. So the classical example is your AS and AI or AR. So continuous murmurs builds up to a crescendo around your S2. Kaya dito, di ba? Malaki yung diagram mo. So it builds up around your S2. While the to and fro murmur can be seen to have two components. Ganito. So it has two components. So to and fro murmur, they are mid-systolic ejection component, or there is a mid-ejection systolic component, and the decrescendo component which disappears as it approaches your S2. Then you can also have your so-called functional or innocent murmurs. So they are soft, mid-systolic in timing, and it is not associated with cardiac abnormalities. So wala siyang mga valvular abnormalities. That's why it's called as functional or innocent murmurs. So they are best heard and recorded at the left lower sternal edge, at the second or third left intercostal space, and it is often musical or grunting in quality. So the sources could be from the RV outflow tract and route of your pulmonary artery due to the increase in the volume and velocity of ejection. So intensity may be magnified by physical activity, excitement, pregnancy, anemia, and thyrotoxicosis, and fever. And about 15% of adults less than 40 years old may have functional murmurs. So functional murmurs can be heard in the pulmonary area, while in pulmonic valve stenosis, you will have moderate severity, and you can hear the murmur at the pulmonic area or pulmonary area. So then you can also have cyclic vascular sounds that is heard in the neck, and this must be differentiated from the carotid bruit. So radiation of murmurs from the base of the heart can also produce a radiation of the murmur, as I've said kanina, like your AS and AR. Then you can also hear murmurs or bruit, high flow bruit in patients who have toxic goiter or a venous hum. So this is an algorithm identifying your murmur. So you first identify whether the murmur is functional or innocent. Now, if it is functional, what is the location or the radiation of the murmur? The intensity. Was it affected by your postural and respiratory changes? And then try to identify the duration. Are there other physical signs Now, if it is normal and no associated cardiac abnormality, no further workup is needed. So it might, and no treatment, so it could be functional only. However, if it is organic, as use the same, you need to identify the location, the radiation, the intensity, postural, if it is affected by postural and respiratory changes, the duration, and some of the physical signs. Then you look at the other ancillary procedures. If they are abnormal, like your ECG and X-ray, you need to work up the patient by doing an echo, or you may even need cardiac catheterization, which is necessary before you proceed with any of your definitive murmurs. So what are those organic murmurs? So they are usually holosystolic, like the murmur of ASD or murmur of your AS or from your PDA. And functional lang, it may be from an innocent murmur or from venous hum. So for peripheral vascular, so your peripheral vascular system, you need to examine by palpating the peripheral pulses, taking note of the pulses bilaterally and compare it with the lower extremity pulses and the upper extremity. So in the upper extremity, if the radial pulse is not palpable, then you need to feel for the brachial, the antecubital, in the antecubital fossa, the brachial in the upper arm, and in the axilla. The lower extremity, you need also to examine the dorsalis pedis, the posterior tibial, podgluteal, and femoral artery. So do not forget also to palpate the external carotids and then compare the strength of their pulsations and try to auscultate if there is bruit for possibility of carotid obstructions, because this is important when you are investigating for causes of cerebrovascular insufficiency or cerebrovascular accident. Now, in recording for your pulse, you record them either as normal, less strong, weak, or absent. So normally strong pulse, 3 plus ito't immo-grading. If it is less strong, 2 plus, and weak, it is 1 plus. And then absent, 0. And you compare it also to the opposite side. You always compare, ha? Bang in one extremity lang. So auscultation over the suspected site of obstruction in the extremities may also elicit a bruit. So blood pressure also should be measured in the upper and lower extremity on both sides, especially where there is a discrepancy in pulse and in a hypertensive patient, especially if the patient is a new patient. Hindi mo alam kung chronically hypertensive ba yung patient or not. Kasi you might be dealing with secondary hypertension, and this one is treatable. Usually mga surgical yan. So an ischemic limb, if you have ischemia, may appear pale, mottled, and cyanotic, cool or cold, with pallor aggravated on elevation of the extremity above the head. So lowering the extremity may also aggravate mottling and cyanosis. So the capillary flush time on dependency after elevation to pallor of the extremity may also give an index of severity of obstruction. Now, capillary flush or reddening should occur almost immediately. So pag ano mo, it will immediately flush or there is reddening. But however, if there is a delay of 15 seconds or more, it may indicate obstruction with poor collateral circulation, and you need to perform an arteriography. This is in order to confirm the diagnosis and location of the occlusion. So arterial insufficiency causes ischemic pain known as claudication. And this is described as feeling of cramps or a dull ache with fatigue in the involved extremity. So it's like your cardiac angina. So the pain is brought about by exertion and relieved by rest. And the pain that is present even at rest is ominous, meaning to say, may indicate poor or absent collateral flow. So the location of pain depends on the site of obstruction. Now, if the pain felt in the calf, it indicates obstruction above the popliteal artery. Now, if the pain is felt in the thigh, it indicates obstruction above the deep femoral artery. Now, if the pain is in the buttock and if it is ischemic, it indicates obstruction at the aortic bifurcation or of the iliac artery. Now, if there is impotence, the disease may be the terminal aortic, so it involving the bifurcation, and this is called as your lyric syndrome. Now, arterial insufficiency may be due to organic or angiospastic disorders. So what are these organic disorders? So one is your arteriosclerosis obliterans. This is an example of slow occlusion. So the peripheral involvement here may be part of a more generalized process that involves the heart, the brain, and other organs. Then you have your Berger's disease or thromboangiitis obliterans. So this disease is seen in males who smoke, and unlike your arteriosclerosis obliterans, it frequently involves the vessels of the upper extremity. Then you have your arterial embolism or acute arterial insufficiency. So the embolism here originates from the heart in most instances because the patient may probably have rheumatic mitral valve disease or have an acute myocardial infarction, but it may also come from big vessels. The embolus usually lodges in the lower extremities, and it may even go to the upper extremities or even the brain and other organs. So the patient may develop stroke or may have other embolic phenomenon in other organs. So there is sudden pain, rapidly progressing ischemia, cyanosis, and impaired sensation and movement, indicating seriousness of the damage. For angiospastic disorders, one is your Raynaud's disease. So this is a disease of digital arteries that cause episodic spasm, pallor, cyanosis, and pain. And this is triggered by cold or emotion. So the spasm may be chronic, and this may lead to gangrene of the involved digits. Raynaud's phenomenon is the same as described above, so except that it is secondary to some other disease. So like, for example, lupus erythematosus, your PAN or polyarteritis nodosa, and thromboangiitis obliterans. So magkaiba hira ha. For Raynaud's disease, primarily on the blood vessel. However, Raynaud's phenomenon is secondary to other diseases affecting your blood vessel. Ha? Acrocyanosis is persistent cyanosis of the hands and feet, usually of unknown etiology and usually affecting females. So this is apparently a benign disorder since there are usually no serious sequelae. So for venous disease, so your peripheral venous disease may take the form of one, venous thrombosis or thrombophlebitis, or two, a chronic venous disease with valve incompetence. So for venous thrombosis, usually this occurs after a prolonged period of inactivity from illness, like in myocardial infarction, kasi inactive siya, immobile, in cerebral stroke and surgery, with or without damage to the vessels of the extremities. So now the danger from venous thrombosis is pulmonary embolism. So this is a very common medical and surgical complication in the Western countries. However, in the Philippines and probably in the Southeast Asian region, pulmonary embolism is rare. So there may be no localizing signs of venous thrombosis, and the first symptom may be maybe chest pain from a pulmonary embolism, or the patient may complain of cough, pain, or unexplained tachycardia, or a rise in your temperature. So you need to carefully examine the legs. So this should be done by making the patient bend the knee. So the patient is recumbent, and then the knee is bent with the feet flat on the bed. So you palpate now the ankle. You palpate from the ankle up, and then carefully press the muscle and take note of the area of tenderness. So there may be tenderness of the calf muscle with dorsiflexion of the foot, which we call as your Homan sign. So you need to measure the cuff, so accurate cuff measurement, because it may reveal an increasing size as compared to the other cuff. So wrapping the sphygmomanometer cuff around the cuff and raising the pressure slowly may elicit pain at levels of 60 to 100 millimeters mercury. Now, in contrast to the cold extremity of arterial ischemia, the leg, when you have DVT or in thrombophlebitis, may be warm and swollen with good pulses. Now, for chronic venous disease with valve incompetence, this will result to varicosities. So valve incompetence may frequently result from thrombophlebitis with recanalization and loss of valve substance with abolition of the unidirectional flow. So this will result in chronic venous stasis with edema, heaviness of the leg, pigmentation, and stasis ulcers around the ankles. So these are some of the tests for venous competence. One is by doing your percussion test for the great saphenous vein. So you have the patient, you let the patient stand and wait for the filling up of the varicose saphenous vein. Then you put the fingers of the right hand on a segment of the saphenous vein below the knee. Then tap the vein sharply above the knee with the left hand. Now, if the fingers of the right hand feel a sharp wave, this is proof of incompetence of the vein. Another test is your Brody-Trendelenburg test. This is for the saphenofemoral competence. So you have the patient lie down, then elevate the involved lower extremity to the vertical position until the veins are empty. Now, with the leg still vertical, you apply a tourniquet around the middle of the thigh. This is enough to occlude only the superficial vein without occluding the artery. Then the patient stand taking note of the time it takes the vein to fill up from below. So the tourniquet is then released within a minute. So the normal reaction should be the veins filling from below in about half a minute and no further filling with release of the tourniquet. Now, rapid filling from above the great saphenous vein upon release of the tourniquet indicates incompetence of the saphenous veins. And if you have rapid filling before release of the tourniquet with further filling from above upon its release, this indicates incompetence of both the great saphenous veins and the communicating veins to the femoral vein. And the third test is your Perthes test for obstruction of your deep veins. So you make the patient walk around for a few minutes. Then you apply a tourniquet to the middle of the thigh with the patient still standing and the varicose veins becomes full. So make him walk around for about 5 minutes with the tourniquet in place. Now, if the varicosities collapse below the tourniquet, the communicating and deep veins are patent and competent. Now, if the varicosities remain the same, both saphenous and communicating veins are incompetent. On the other hand, if the varicosities increase in size, and especially if there is pain, there is obstruction of the deep veins. So before we end, I would like you to share with you this statement from Dorizis, that auscultation requires continual practice to maintain finesse of the ear and exact perception of the heart sounds, just as the musician needs to practice agility and suppleness of the fingers. So I guess this is my last slide. Thank you for listening.